Good morning, everyone. Today I'm going to talk about the second part of the topic entitled the physiology of arrhythmias. In the first part of the arrhythmia lecture, I covered several points, including the definition of the term arrhythmia, and then how the abnormalities or what are the mechanisms that will lead to arrhythmia, the types of arrhythmias, the causes of arrhythmias, and then I started to talk about the classification of arrhythmias. There are arrhythmias that originate from abnormalities in the SA node, and then we have atrial arrhythmias, we have junctional arrhythmias, and ventricular arrhythmias. And in the first part, I covered the sinus arrhythmias and also the atrial arrhythmias. And today I'm going to finish the classification of arrhythmia, which includes the junctional arrhythmias and the ventricular arrhythmias, and also I will cover the different types of the heart block. And finally, I will explain the principles of emergency or short-term and long-term treatments of arrhythmias. As I said in the previous lecture, arrhythmia can be divided according to the heart rate and also to the origin of the arrhythmia. So based on the heart rate abnormality, we know that the heart rate normal range is between 60 and 100 beats per minute. So any heart rate below 60 is a bradyarrhythmia or bradycardia, and this can be simple bradycardia or heart block, as we'll see at the end of this lecture. While arrhythmias that have a heart rate above 100 beats per minute are called tachyarrhythmias. And to make things simple, or to know quickly, or to come to the correct diagnosis, we check the QRS complex duration. If it is a narrow QRS complex, which means the duration is less than 0.12 seconds or 3 small boxes, it is a narrow complex arrhythmia, and this includes the atrial arrhythmias, atrial fibrillation and atrial flutter, plus the atrial tachycardia and junctional arrhythmias, and also it could be caused by sinus tachycardia. If the QRS complex is wide, more than 0.12 seconds, then this means that it is an arrhythmia that originates in the ventricles, and we call this broad complex arrhythmia, and includes mainly the ventricular tachycardia and ventricular fibrillation. The QRS complex is broad in ventricular arrhythmias because the action potential is conducted through the contractile cells of the ventricles. They have a lower speed of conduction compared to the autorhythmic cells. That's why they take longer time to propagate through the ventricles and cause depolarization. And we know that QRS in the ECG represents the ventricular depolarization. So longer depolarization through the ventricular contractile cells will lead to longer or broad QRS interval or complex. So as I said in the previous part, or in part 1, we covered sinus node arrhythmias and also the atrial arrhythmias. Today we are going to talk about junctional arrhythmias that arise in the AV junction or the atrioventricular junction, and then the ventricular arrhythmias, and later on the different types of heart block. What are the junctional arrhythmias that we can see in different patients' ECG? Number 1, we can see the premature junctional complexes. And then number 2, junctional escape rhythm. And this is the rhythm that will become, or where the AV junction will become the pacemaker of the heart due to the failure of the SA node. And this junctional escape rhythm will be at a rate of the firing of autorhythmic cells in the junction between 40 to 60 beats per minute. Then we have another type of arrhythmia called accelerated junctional rhythm, and it is regular between 60 and 100 beats per minute, and we'll see how does it look like in the ECG in one of the slides. And finally, we have junctional tachycardia, where we have regular rhythm and heart rate between 100 to 160 beats per minute. If you notice that junctional rhythms or junctional arrhythmias, apart from the premature junctional complexes, are all regular, but the classification depends on the heart rate. 40 to 60 beats per minute, we call them junctional escape rhythms, and between 60 to 100 beats per minute, they are accelerated escape junctional rhythm or accelerated junctional rhythm. And if the rate is between 100 to 160 beats per minute, they are junctional tachycardia. As I said, they are all regular, but they differ in their rate, escape rhythm, accelerated junctional rhythm, and we have the junctional tachycardia. Junctional arrhythmias, as the title says, they are arrhythmias that originate in the AV junction, the area around the AV node and the bundle of His. And the arrhythmias occur when the SA node is suppressed and fails to conduct impulses, or when a block occurs in the conduction. And the electrical impulses may then be initiated by pacemaker cells in the AV junction, because the AV junction, like other parts of the conduction system of the heart, are composed of autorhythmic cells that have their own frequency of spontaneous action potential generation. Because the AV junction is located in the lower part of the right atrium near the tricuspid valve, impulses generated in this area cause the heart to be depolarized in an abnormal way, which means that the impulse can be conducted retrogradely to the atria and anterogradely to the ventricles. So the impulse moves upward and causes backward or retrograde depolarization of the atria, and inverted P waves will be seen in leads 2, 3, and AVF. Leads in which the P wave are normally upright and the PR interval will become short, less than 0.12 seconds. We know that the normal PR interval range is between 0.12 to 0.2 seconds, or 3 to 5 small squares or small boxes. The impulses also will move down towards the ventricles, causing forward or antigrade depolarization of the ventricles and an upright narrow QRS complex. So the QRS complexes will be normally seen, they will be narrow, less than 3 small boxes. Arrhythmias that cause inverted P waves on an ECG may be atrial or junctional in origin, because if the arrhythmias or the atrial arrhythmia is originating from a focus down in the atrial wall, very close to the AV junction or to the junction between the atria and the ventricles, it can also propagate retrogradely and cause an inverted P wave. But there will be a difference in the PR interval duration, as we'll see in the coming slide. So when the pacemaker fires in the AV junction, which is the source of the arrhythmia or the origin of the arrhythmia, the impulse may reach the atria or the ventricles first. Therefore, the inverted P waves and the following QRS complexes have no consistent relationship. So it depends on which chamber will receive the action potential first. So if the impulse is conducted to the atria first, before the ventricles, we'll see an inverted P wave before the QRS interval or complex. So this is a junctional arrhythmia where the impulse is conducted to the atria first. So the atria will be depolarized. The mean atrial vector will be propagating away from the positive electrode of the lead, so the P wave will be inverted. Then the impulse will be conducted to the ventricles, and we have a normally looking narrow QRS complex. But if the impulse is conducted to both the atria and the ventricles at the same time, the P wave is expected to be inverted, but since the conduction happens at the same time, the inverted P wave will be hidden in the QRS complex, and this is in the case of simultaneous conduction to both the atria and the ventricles from the junction, which is the pacemaker of the heart in the case of junctional arrhythmia. If the impulse is conducted to the ventricles first, what we'll see is the QRS complex, normally looking QRS complex first, then it will be followed by the P wave or inverted P wave, because ventricular depolarization will happen first, and this will be followed by atrial depolarization in a retrograde manner. So the P wave will follow the QRS and it will be inverted, and as I said, this is the case when the ventricles will receive the action potential from the junction or the focus of arrhythmia, which is the junction first. Atrial arrhythmias are sometimes mistaken for junctional arrhythmias, especially if we cannot determine the P wave, or we cannot see the P wave like here where it is hidden. The PR interval will help to determine whether an arrhythmia is atrial or junctional. An arrhythmia with an inverted P wave before the QRS complex and PR interval between 0.12 to 0.2 seconds usually originates in the atria. It will take the normal time for traveling retrogradely into the atria. An arrhythmia with an inverted P wave before the QRS complex and a PR interval less than 0.12 seconds usually originates in the AV junction. So this is one of the ways to differentiate between atrial and ventricular AV junctional arrhythmias if the P wave is inverted. And now let's talk about the different types of junctional arrhythmias. Number one in the list is the premature junctional complexes. So we have otherwise normal ECG, but from time to time we see a premature beat, which is the premature junctional complex. We can see one here and we can see another one here. Otherwise the QRS complexes are regular. We can see the P wave, the QRS complex, T wave, and so on. They keep repeating, but here we can see one premature junctional complex and another one here, and you can see here clearly the inverted P wave and another one here. So the rhythm is irregular, atrial and ventricular rhythms. The rate is within normal, 100 beats per minute. The P wave is inverted and it precedes or comes before the QRS complex when we have a premature junctional complex. Otherwise the P waves are quite normal. The PR interval is 0.14 seconds for the underlying rhythm and 0.06 seconds for the premature junctional complex. You can see, as I said in the previous slide, here we have a short PR interval in the case of the premature junctional complexes. The QRS complex is within the normal. It is a narrow QRS complex, and the T wave is normal. Also the QT interval is within the normal range, so the rhythm is irregular in the case of the premature junctional complex, and this is the only junctional arrhythmia that comes with irregular rhythm. The premature junctional complex is a beat that occurs before a normal beat. That's why we call it premature, and causes an irregular rhythm. This ectopic beat occurs when an irritable location within the AV junction acts as a pacemaker and fires either prematurely or out of sequence. So it comes at a place that is unexpected. The atria are depolarized in retrograde fashion, causing an inverted P wave, and this P wave can be seen before, within, or after the QRS complex. The ventricles are depolarized normally. That's why we see normal narrow QRS complexes. The junctional escape rhythm is a rhythm that is regular and it happens when we lose the natural pacemaker of the heart, which is the SA node. When the SA node stops firing, so now the junction or the AV junction will take the lead and will become the pacemaker of the heart. So as I said, the rhythm is regular. The rate is between 40 and 60 beats per minute. The P waves are inverted, as we can see them here, preceding the QRS complex. The PR interval is shorter than normal, 0.10 or 0.1 seconds. The QRS complex is within the normal range. The T waves are normal. So the ventricular electrical activities are quite normal. The Q interval, again, it is within the normal. As I said, the rhythm is regular and heart rate is usually between 40 and 60 in general for the junctional escape rhythm. It occurs when higher pacemaker sites slow down or fail to fire or conduct as a compensatory mechanism to prevent ventricular standstill. So ventricular or junctional escape rhythm should never be suppressed. You should never aim in your treatment to stop this kind of junctional or this type of arrhythmia, because if you stop it, then the ventricles will stop and this will lead to the death of the patient. The junctional escape rhythm can be caused by any condition that affects or disturbs the SA node function or enhances the AV junction automaticity, like vagal stimulation that has an inhibitory effect on the SA node, digitalis toxicity, inferior wall myocardial infarction that will affect the SA node, and rheumatic heart disease. The accelerated junctional rhythm is similar to the escape junctional rhythm, but the irritable focus in the AV junction fires at a higher rate. So they have exactly the same features except for the rate, which is higher, between 60 and 100 beats per minute. As you can see here, we have a regular rhythm and we cannot see any P waves before or after the QRS complexes. So the inverted P waves or the P waves that are expected to be inverted are hidden within or embedded within the QRS complex. And here, as you see, the rhythm is regular. The rate is 80 beats per minute. The P waves are absent because they are embedded or hidden in the QRS complex. Since we don't have P wave, we cannot measure the PR interval. The QRS complex is normal, within the normal range, and the T waves are normal. So the ventricular electrical activity, again, they are normal in junctional arrhythmias. The QT interval is a bit shorter due to the higher rate. So this junctional or accelerated junctional rhythm is regular, and the heart rate is usually between 60 and 100 beats per minute, and it is 80 in this example. It is caused by an irritable focus in the AV junction that speeds up to take over as the heart's pacemaker. The atria are depolarized by means of retrograde conduction, and the ventricles are depolarized normally. That's why we see normal or narrow QRS complexes followed by normal T waves. The accelerated junctional rhythm can be caused by different conditions that affect the SA node or the AV node automaticity, like digitalis toxicity, hypokalemia, inferior or posterior wall myocardial infarction, rheumatic heart disease, and valvular heart diseases. Now we come to the last type of arrhythmia under AV junction arrhythmia, which is junctional tachycardia. In a junctional tachycardia, again, the rhythm is regular, but we have a higher rate between 100 and 160 beats per minute. So if you see here in this trace, you might think that this is an inverted T wave. These are the QRS complexes. They are at regular. They have regular rhythm. And we can also calculate the rate, which is about 115 beats per minute. And here you might think that this is an inverted T wave. Actually, this is an inverted P wave that comes following the QRS complex, because the conduction goes, or the electrical impulses will go to the ventricles first and then to the atria, and since it is retrograde conduction in the atria, the P waves will be inverted. So here the rhythm, atrial and ventricular rhythms are regular. Rates for both the atria and ventricles is 115 beats per minute. The P waves are inverted and they follow the QRS complexes. The PR interval is unmeasurable since the P waves are coming after the QRS, so you cannot measure that distance or that interval. And then you have the QRS complex, which is within the normal range, narrow QRS complex. The T waves are normal and the QT interval is 0.36 seconds. So in junctional tachycardia, the rhythm is regular. Heart rate is 100 to 160 beats per minute. In junctional tachycardia, 3 or more premature junctional complexes occur in a row. This supraventricular tachycardia occurs when an irritable focus from the AV junction has enhanced automaticity. It fires at a fast rate. And this high firing rate will override the SA node and will function as the heart's pacemaker. Now the AV junction will become the pacemaker in junctional tachycardia. Junctional tachycardia can be caused by digitalis toxicity, which is the most common cause, inferior or posterior wall myocardial infarction or ischemia, congenital heart disease in children, and swelling of the AV junction after heart surgery, so post-surgical complication or post-operative complication. Just to study this syndrome before we go to the ventricular arrhythmias, which is the Wolff-Parkinson-White syndrome. The problem in Wolff-Parkinson-White syndrome that there is a conduction bypass that develops outside the AV junction, and this bypass or this bundle connects the atria directly to the ventricles away from the AV junction. Like you can see here, we have an accessory pathway of impulse through the bundle of Kent. So what happens in Wolff-Parkinson-White syndrome or WPW syndrome? A conduction bypass develops outside the AV junction and connects the atria with the ventricles. We call this accessory pathway in this example as the bundle of Kent. The conduction bypass or this pathway could be present between the right atrium and ventricle or the left atrium and ventricle, so we have different conditions. Impulses aren't delayed at the accessory pathway because we know that impulses are normally delayed at the AV junction, but in this bypass pathway or the accessory pathway, the impulses are not delayed. So conduction is normally fast. And this lack of delay will lead to a start of early depolarization of the ventricles, because the impulse will arrive here and start to depolarize the ventricles and will generate an additional wave just at the beginning of the QRS. We call the delta wave, which represents the early depolarization of the ventricles. Retrograde conduction or circus re-entry and re-entrant tachycardias can result. This impulse could go back through the AV junction in a retrograde manner and will cause re-entry, and this can lead to different types of arrhythmias. This syndrome causes a shortened PR interval because we said the depolarization or ventricular depolarization will start early, so this will affect the duration of the PR interval, so it will be less than normal, usually less than 0.1 seconds, and widening of the QRS complex. It will be more than 0.1 or 0.12 seconds or 3 small squares or boxes. The beginning of the QRS complex may look slurred because of the altered ventricular depolarization or the early ventricular depolarization. This hallmark sign of Wolff-Parkinson-White syndrome is called the delta wave, as I mentioned earlier. I mentioned this syndrome in conjunction with the junctional arrhythmias because usually it causes re-entry circuits or re-entrant tachycardia that involves the AV junction. Now let's talk about the different types of ventricular arrhythmias. Ventricular arrhythmias are arrhythmias that arise in the ventricles, any part of the ventricles. As I said in part 1 of this topic, arrhythmias could go asymptomatic or can be serious enough to cause death. And also I said that atrial arrhythmias are less serious than ventricular arrhythmias. Usually ventricular arrhythmias are life-threatening if left untreated. So please be careful, and you should know the different types of ventricular arrhythmias because their prompt treatment can save the patient's life. What are the different ventricular arrhythmias? We have premature ventricular complexes, PVCs. We have ideoventricular rhythm, which is similar to the escape junctional rhythm, but the rate is different, and the shape of the QRS complex is also different. Accelerated ideoventricular rhythm, like the accelerated junctional rhythm, the same concept, but again, the rate and the shape, the heart rate is different, and the shape of the QRS complex is different. Then we have the ventricular tachycardia. It could be regular or irregular, and the heart rate is between 100 to 250 beats per minute. And then ventricular flutter, where the heart rate is high, between 250 to 350 beats per minute. And finally, the most serious ventricular arrhythmia, which is ventricular fibrillation, that has a heart rate above 350 beats per minute. The hallmark of any ventricular arrhythmia is a broad QRS complex. A QRS complex that is, or the duration of the QRS complex is more than 0.12 seconds or 3 small boxes. Whenever you see a QRS complex or wide QRS complex, please think about ventricular arrhythmia. Ventricular arrhythmias, as I said, originate in the ventricles below the bundle of His. They occur when electrical impulses depolarize the myocardium using a different pathway from the normal impulses. So the conduction is through the contractile cells rather than the autorhythmic cells. The QRS complex is wider than normal because the conduction through the contractile cells has a lower speed because of the prolonged conduction time through the ventricles, and the T waves will deflect in opposite directions. Because of the prolonged depolarization, we know that in the ventricles, the fibers that depolarize first will repolarize last. But because the fibers that depolarize first will take longer time, so they are the fibers that will repolarize last. So they will be similar to the atria, and therefore the T wave will be inverted. The P wave is absent because atrial depolarization does not occur, or in other cases it could be present but buried in the QRS complex because the QRS complex is broad. Even if there is retrograde propagation of the impulse from the ventricles through the AV junction back to the atria, the P waves will be inverted, but they will be buried in the QRS, so we can't see the P waves. When electrical impulses are generated from the ventricles instead of the atria, we lose the atrial kick that is responsible for the last 30% of the ventricular filling during diastole or ventricular diastole. So we are going to lose about 30% of the cardiac output. Patients with ventricular arrhythmias may show signs and symptoms of cardiac decompensation, including hypotension, angina due to the poor coronary blood flow, syncope due to poor cerebral blood flow and respiratory distress. Although ventricular arrhythmias may be benign, they are potentially deadly because the ventricles are ultimately responsible for cardiac output. That's why I said ventricular arrhythmias should be taken more seriously compared to the atrial arrhythmias, as ventricular arrhythmias could be serious enough to compromise the cardiac output and lead to death. Rapid recognition and treatment of ventricular arrhythmias increases the chances of successful resuscitation. So this is the ultimate goal, to recognize the ventricular arrhythmias quickly and give the patient the appropriate treatment to conserve his cardiac output. So now let's talk about premature ventricular complexes. Here we can see almost regular rhythm, but because we have some premature ventricular complexes, the rhythm becomes irregular. So if there are no complexes, you can see that the rhythm is otherwise regular. Due to the presence of the premature complexes that arise from the ventricular wall or ectopic foci in the ventricular wall, we have an irregular rhythm. The heart rate is 100 beats per minute. The P waves are absent with the premature complexes. For the other complexes, we can see here small P waves. But in the premature ventricular complexes, we cannot see any P wave preceding the QRS complexes. The QRS complexes are wide for the premature complexes, and otherwise they are normal. The PR interval is 0.12 seconds in the underlying rhythm, where we have normal PQRS-T complexes. The QRS complex early with bizarre configuration and duration of 0.14. So it is beyond the normal value, which is 0.12. Otherwise, in the normal QRS complexes, the duration is 0.08, which is within the normal range. The T waves are normal for the normal complexes, but they are inverted for the premature junctional complexes. So this here, this is not an S wave. This is an inverted T wave. This one and this one and this one, the last one. So the rhythm is irregular. A premature ventricular complex is an ectopic caused by electrical irritability in the ventricular conduction system or the muscle tissue itself, i.e. the contractile cardiomyocytes. This irritability may be provoked by electrolyte disturbance, hypoxia, acidosis, ventricular enlargement, caffeine, alcohol drug intoxication, and myocarditis. Now let's go to the ideoventricular rhythm. Just from looking at this ECG, we can predict that there is a bradycardia. The heart rate is too slow. So the heart rate is 35 beats per minute. We don't see any P waves. So P waves are absent. PR interval is unmeasurable because of the lack of the P wave or the P waves. The QRS complex is wide and bizarre, and T waves deflections are opposite to the QRS complex. So this is the QRS here, and the T wave is inverted opposite to the main QRS components. So here we have wide and large amplitude S wave. QT interval is 0.6 due to the bradycardia. So here the rhythm is regular and the heart rate is between 20 to 40 beats per minute, and it is 35 in this example. This ideoventricular rhythm acts as a safety mechanism to prevent ventricular standstill when no impulses are conducted to the ventricles from above the bundle of His. This happens when the SA node fails to be the pacemaker, and also the AV node fails to take over the function as a pacemaker. So now the ventricle will become the pacemaker, but the heart rate is very low. The cells of the His-Purkinje system take over and act as the heart's pacemaker to generate electrical impulses. Now we have an accelerated ideoventricular rhythm. By the way, ideo means on its own, so the ventricle is generating rhythm on its own. So it is a bit similar to the previous type of arrhythmia, but it is accelerated. The rate is higher. So the rhythm is regular. Heart rate is 40 to 100 beats per minute. The ideoventricular rhythm can occur as accelerated ideoventricular rhythm. As I said, similar to the previous slide, but it is accelerated where the rate is between 40 and 100. The ideoventricular rhythm occurs when all of the heart's other pacemaker fails to function, or when the supraventricular impulses cannot reach the ventricles because of the block in the conduction system. So here we can notice that we have the QRS complexes are bizarre. So here we have a wide S wave followed by a T wave in the opposite direction. And this is a key feature of the ventricular electrical activity in case of ventricular arrhythmias. We see the main QRS component in one direction, while the T wave is in the opposite direction. So if I have in this example an R wave, the T wave will be opposite in the opposite direction. In this case we have a large broad S wave, the T wave is in the opposite direction. So the QRS complexes are wide and bizarre, and the T waves come in opposite direction to the main component of the QRS complex. Ventricular tachycardia. Here you can see the again wide and bizarre QRS complexes. So these are S waves, and we see the T waves, another S wave, another T wave. So the rhythm, as you can see, is regular. The rate is high, above 100. The P waves are absent because there is no conduction to the atria, or the P waves are hidden or embedded in the broad QRS. PR interval cannot be measured. The QRS complex is broad, here 0.16 seconds. The T waves are opposite in direction of the main QRS complex, as I showed here. These are all the T waves up, and in summary, the rhythm is regular or irregular depending on the case. Heart rate between 100 to 250 beats per minute. It is also called VTAC, ventricular tachycardia, and may precede ventricular fibrillation and sudden cardiac death. So if you see such an ECG for a patient, be careful because he might go into ventricular fibrillation and death, so you should treat him promptly. Ventricular tachycardia usually results from increased myocardial irritability, which may be triggered by enhanced automaticity or re-entry within the Purkinje fiber system. It can also be caused by myocardial ischemia, myocardial infarction, coronary artery disease, valvular heart disease, heart failure, cardiomyopathy, electrolyte imbalances, and drug intoxication. There is a certain type of ventricular tachycardia called the Torsades de Pont. In the Torsades de Pont, we have the QRS complexes that are wide and bizarre with phasic variation, and they twist around the baseline. So if we have a baseline, we have certain waves or certain QRS complexes on one side, then they twist to the opposite side and then back to the same side. So we call the Torsades de Pont, or Torsades de Pont, which is a French word. Torsades de Pont, which means twisting about the points, is a special form of polymorphic ventricular tachycardia. The hallmark characteristics of this rhythm are QRS complexes that rotate or twist about the baseline, deflecting downward and upward for several beats, like we see here in this rhythm. The rate is between 100 to 250 beats per minute. usually with an irregular rhythm, and the QRS complexes are wide with changing amplitudes. You can see the amplitudes are not constant like the previous slides. The P waves are usually absent. And now let's talk about ventricular fibrillation, which is the most serious type of arrhythmia in general. So the most serious of all the ventricular arrhythmias, and also the most serious of all types of arrhythmia. And it is a life-threatening condition because the ventricles fail to eject enough blood into the main or great blood vessels, and this will compromise the blood flow into the circulation. We have two types. We have the coarse ventricular fibrillation, like we can see here in the upper strip here. So the presence of large fibrillatory waves indicates coarse ventricular fibrillation. And we have certain types of ventricular arrhythmias where we have fine ventricular or small fibrillatory waves that indicate fine ventricular fibrillation. The rhythm is chaotic. Rate you cannot measure, but it is above 350 beats per minute. That's why it is too high to be measured. P waves are absent. The PR interval cannot be measured. QRS complexes are indiscernible. So you cannot even identify which component is which wave in both strips here. T waves are again indiscernible. The QT interval is indiscernible because you cannot discriminate between the different waves. And this is ventricular fibrillation, also called VFib, which is a chaotic pattern of electrical activity in the ventricles in which electrical impulses arise from many different foci in the ventricles. It produces no effective ventricular contraction, and therefore there is no cardiac output, and this is the major problem. So the cardiac output will be very low, and this will compromise the blood flow and lead to death. Before concluding the discussion about the ventricular arrhythmia, I want to talk about two important things. These are asystole and the pulseless electrical activity. As you can see here in this trace, we can't see any electrical activity, just we can see a flat or almost flat line. So the absence of electrical activity in the ventricles results in a nearly flat line. Ventricular asystole or asystole is ventricular standstill. This condition happens if the heart fails to generate an escape rhythm in the junction or the ventricles, in case where the SA node is not working well or fails to generate action potentials. The patient is completely unresponsive with no electrical activity in the heart and no cardiac output. Without rapid initiation of cardiopulmonary resuscitation or CPR and appropriate treatment, the situation will quickly become irreversible and will lose the patient. Anything that causes inadequate blood flow to the heart may lead to asystole, including myocardial infarction, severe electrolyte disturbances, massive pulmonary embolism, prolonged hypoxemia, severe uncorrected acid-base disturbances, electric shock, drug intoxication, cardiac tamponade, and hypothermia. Other condition is pulseless electrical activity, or PEA. When you check the ECG, it is quite normal. The rhythm is regular, the heart rate is within the normal range, all the durations and all the intervals and the amplitudes are quite normal, but the main problem is that there is no pulse. In this condition, the electromechanical activity of the heart is dissociated. So electrical activity is not translated into contraction. In pulseless electrical activity, the heart muscle loses its ability to contract even though electrical activity is preserved and generates normal ECG. As a result, the patient goes into cardiac arrest, because if there is no contraction, there is no cardiac output and we lose the blood flow to the vital organs. The ECG shows organized electrical activity, but there is no pulse. It can be caused by hypovolemia, hypoxia, acidosis, tension, pneumothorax, cardiac tamponade, massive pulmonary embolism, hypothermia, hyperkalemia, massive acute myocardial infarction, drug overdose or intoxication, etc. Now let's talk about the different degrees of atrioventricular blocks or AV blocks. We have 3 degrees. The first degree AV block, then we have a second degree AV block, type 1, which is Mopitz 1 or Winkelbach, and we have type 2 or Mopitz 2 or Hay AV block, and finally we have the third degree or the complete AV block when the AV junction fails to conduct any signals from the atria to the ventricles. So what is the problem here? Here there is a problem in the conduction of impulses from the atria to the ventricles through the AV junction due to some abnormality or pathology in the AV junction. Let's start with the first degree. First degree AV block, as you can see here in this trace, everything seems to be normal or within the normal range, regular rhythm rate within the normal range, 75 beats per minute. The P waves are normal, but the main problem or the main abnormality is the prolongation of the PR interval. Here it is 0.32 seconds. As you can see here, 8 small squares or boxes, which is equivalent to 0.32 seconds. So we have a prolonged PR interval. If we check the PR interval in all the cardiac cycles, it is 0.32. So there is a constant or fixed prolongation of the PR interval beyond the upper limit of the normal range. So in the first degree AV block, it occurs when impulses from the atria are consistently delayed during conduction through the AV node. The PR interval is more than or longer than 0.2 seconds. As I said, the PR interval is constantly prolonged, so it will be the same prolongation in all the successive cardiac cycles. It will be 0.32 here, 0.32 here again, and so on. In the second degree AV block or type 1, second degree AV block, which is called Mopitz type 1, you can see here that there is progressive prolongation. So the PR interval is prolonged, but it is not fixed. So with each beat, it becomes longer and longer, and then until one beat is missing. As you can see here, also called Mopitz type 1 block. Type 1 second degree AV block occurs when each successive impulse from the SA node is delayed slightly longer than the previous impulse, and then the pattern will continue until an impulse fails to be conducted to the ventricles, and the cycle then repeats. As you can see here, it is prolonged. Let's start from here. It's prolonged, now longer, and then one is missing. Again here, PR interval prolonged, then much longer, then a missing QRS complex here. Okay, so this is the difference. Please differentiate between this one and the sinus pause, because in the sinus pause the PQRS interval as a whole is missing, but here we can see a P wave but a missing QRS. So this is type 1 second degree AV block. Now in the type 2 second degree AV block, what is happening is that the atrial rhythm is regular, the PR interval is prolonged, and this prolongation is constant like type 1, but a QRS complex is absent after a while. So after several complexes we have a missing QRS complex, also known as Mopitz type 2 block. It occurs when occasional impulses from the SA node fail to conduct to the ventricles. So as I said, there is no progressive PR interval lengthening. It is already prolonged and constant. So it is not like the type 1 second degree AV block. In type 1 second degree AV block, the PR interval becomes progressively prolonged, and then one QRS complex will be missing. Here, the PR interval is constantly prolonged, and after several beats, there is a missing QRS complex. And the third degree AV block, and which is called complete block or complete heart block. The third degree AV block occurs when impulses from the atria are completely blocked. So no single impulse will pass through the AV node to the ventricles. So what will happen? We will see that the atrial rhythm is completely dissociated from the ventricular rhythm. Here these are the P waves of the atrial rhythm, which are regular. So the atrial rhythm is regular, and the ventricular rhythm is regular. So it is like an ideoventricular rhythm, but there is no relation between the atrial rhythm or the P waves and the QRS complexes. So atrial rate of the atrial beats is 90 beats per minute. The ventricles, the ideoventricular rhythm, is 30 beats per minute. P waves are normal. The PR interval varies because sometimes the P comes before a ventricular beat. The QRS complexes are wide beyond the normal or the upper limit of the normal range, above 0.1 or 0.12 seconds, because these are ventricular beats, and the T waves are normal. The QT interval is prolonged due to the very low ventricular rate. So this is the third degree AV block or the complete heart block. It is complete dissociation between the atrial rhythm and the ventricular rhythm. There is no relation between the P waves and the QRS complex. You cannot relate them to each other in the third degree AV block. Now we conclude this part of this session by discussing the principles or listing the principles of arrhythmia treatment. What is the main aim of arrhythmia treatment? The main problem in arrhythmia is that the cardiac output will become very low, and this will compromise the blood flow to the vital organs like the heart and the brain. So our main goal in treating patients with arrhythmia is to restore the cardiac output and also treat the underlying condition later on, because cardiac output is number one goal of treatment, or restoration of cardiac output is number one goal of treatment. The aim is to restore cardiac output as soon as possible to avoid damage to the brain, heart, kidneys, and other organs. We have emergency treatment, and this depends on the type of arrhythmia. One of them is the chest compression, because if you don't have a defibrillator, you have to start the CPR or the cardiopulmonary resuscitation, and this is of great help in pulseless electrical activity and ventricular fibrillation. The other treatment option is cardioversion, which is electrical defibrillation of shockable rhythm, like ventricular fibrillation, but this is not good for pulseless electrical activity, because in pulseless electrical activity the ECG is normal. The main problem is the dissociation between electrical and mechanical activity. So cardioversion or electrical defibrillation is not suitable for all types of arrhythmia. And then the third line of treatment is medication, and this will be covered in the pharmacology lecture. Then we have long-term treatment in patients that have recurrent arrhythmias, or their arrhythmias, if might happen or repeat later on, can lead to death. So here the options are pacing, we insert the pacemaker, and medications, again it will be covered in the pharmacology lecture. Avoid fatigue, stress, excessive caffeine and nicotine, and also stop medications that might cause arrhythmias, because some drugs have their side effects on the heart and might lead to arrhythmias. So we should revise and during history taking the medication history of the patient and try to pick up any drug that has a side effect of causing or affecting the heart and causing arrhythmia. With this slide, I finished today's session. Thank you very much. and I wish you all the best.